Hello and welcome to this video on health promotion in family medicine from the Department of Family Medicine at RCSI Perdana. My name is Professor Anthony Cummins. This will serve as an introduction to health promotion and as a precursor to the collaborative video that you will produce in week 2. This is an outline of the video. We'll look at some learning outcomes and then ask the question, what is health promotion? We look at what is it that prevents people from adopting changes in unhealthy behavior to make their behavior more healthy, make some lifestyle changes and so forth. Even if they have good intentions, what is it that prevents us from seeing these challenges through? We then look at screening, and we look at the stages of change model of human behavior, which is quite important in understanding how motivational interviewing may be helpful. We look at various brief intervention strategies, and then we'll give you a clinical scenario from which you will develop your video. These are the learning outcomes. You should be able to explain the role and the challenges of health promotion within family medicine. You should also be able to discuss knowledgeably screening as it's utilized in family medicine. You should be able to outline the behavioral change cycle and demonstrate how to apply motivational interviewing techniques to aid a change in healthy behavior. And finally, you should be able to combine all of these together in a collaborative group in the making of your educational health promotion video. Can you think now of some examples of health promotion that you've seen in family medicine or elsewhere already? So have a think about that. You've probably come across some or all of the following. Advice about smoking cessation, perhaps even the evidence base for various strategies like nicotine replacement therapy. But more importantly is motivating the person to make that change and setting in mind a process that helps them to successfully achieve this. Similarly, with reducing harmful alcohol consumption, we now know that concerns about alcohol consumption in the wider world has led recently in the UK to a reduction in the safe upper limit for men from 21 units down to 14. And exercise and physical activity. Quite a number of people take no significant physical activity from one end of the year to the next. And this graph on the front here looks at the different ages and the different over time scale from 1988 to 2002. This is European data showing how men particularly take less physical activity than women up to that year 2002, especially in the older age ranges. So the age ranges are split into 18 to 34, 35 to 54, and 55 plus. So in the older age groups, women take more physical activity than men. We're now looking also at dietary advice, because one of the biggest challenges we now face in health is obesity and its related problems with coronary artery disease and type 2 diabetes mellitus and metabolic syndrome. And also this immunisations. There are a variety of immunisations available, and in the real world there have been concerns, albeit not soundly based, over some years about the potential link between, for example, MMR vaccine, measles, mumps and rubella, and childhood autism, for which there is no link. However, a rogue paper published by Dr. Andrew Wakefield and published in The Lancet some years back has led to a huge decline in rates of immunization with MMR, and the problems from that has been the re-emergence of measles and mumps. There's also the issue of screening services. With screening, though it's generally a good thing, where does it work well and where does it not work well? The evidence for prostate cancer screening is poor, and we'll touch on that later. There is no lung cancer screening program available in Ireland simply because there is no evidence of an effective screening program that doesn't have either high false positives and negatives. There's some increasing concern now about the level of overdiagnosis in women through mammographic breast screening. That it refers to the situation where a woman is diagnosed with breast cancer but may not have breast cancer, may have a non-malignant breast lesion such as a fibroadenoma or cystic breast disease, or also may have a breast cancer but it's slow growing and is unlikely to harm her or kill her, but she may still be urged to go ahead and have the lumpectomy or mastectomy and follow up with chemotherapy, etc. This is a very contentious area at the moment, and the rates of overdiagnosis in some countries are deemed to be significantly high and too high to be justifiable. There are effective other screening programs in Ireland for cervical cancer and bowel cancer, and also for diabetic retinal screening. In Malaysia, the situation in terms of disease levels are similar to the West in the sense that the levels of cardiovascular disease and other vascular disease is quite high, and that's associated with increased related conditions such as obesity, hypertension, type 2 diabetes mellitus, and so on. We can see on this graph here from 2000 to 2012 that the level of diabetes has remained fairly steady. The level of respiratory disease has had a reduction until about 2007, and then has shown a slight but steady increase since then. Cancer levels are fairly steady, and vascular disease similarly had shown a significant reduction, but has now started to come up again since the mid-2000s. And we can see on the lower graph here the causes of premature mortality due to NCDs shows that the biggest contributory factor is this red hatch zone here, which refers to cardiovascular disease. This is a similar graph in women. This one is in men. You can see the level of cardiovascular disease is significant in both, but more so in men. So that's a big challenge for health promotion and encouraging motivational change and change in health behavior. So health promotion is the process of enabling people to increase control individually over their health and to improve their health. So it moves beyond the focus on individual behavior towards a wide range of social and environmental interventions. So for example, this would involve government policy on the subvention or support financially with low-fat foods, and support generally with dietary measures, maybe providing exercise facilities for people to engage in this more easily, and so forth. It isn't just about the individual patient, but within the individual patient, techniques of motivational interviewing are very important in order to encourage change. Worldwide, the same diseases that kill prematurely in Malaysia and Ireland are the same all over the world. Ischemic heart disease and stroke, then respiratory disease like COPD and lower respiratory infections, bronchitis and so on, and then to a lesser extent others such as infectious diseases causing diarrhea, HIV, AIDS, etc. But the big killers are the vascular and respiratory diseases. And you can see how these have changed from 2000 in purple to 2012. You can see the levels have increased. The overall level has increased, but there's been definitely an increase over those 12 years. And that's set to increase even further, particularly with other vascular diseases such as heart failure and stroke. Without identifying hypertension with some rigor, then levels of stroke and heart failure are said to increase in the older age groups who are surviving heart attacks. This is another way of demonstrating or showing the same sort of graph. This is from the NHS Atlas of Risk, which looks at leading causes of death in a perspective. So we're obviously very concerned about wars, but wars kill very few people relatively. And so on, if you go up and up and up, the levels get higher and higher until you get to the zenith with heart, circulatory disorders, cancers, and respiratory diseases. These are the big three. And if you look at individual factors that lead to that, then what leads to the big increase in vascular diseases in general are high blood pressure, high cholesterol, and obesity. So there's nothing new here. This is something we know already. And this is so well covered in the media that the general population are also pretty much aware of this. But how do you encourage individuals to make changes that they need to in order to reduce the impact of their blood pressure on their likelihood of premature death, or their cholesterol, or their weight and the BMI? So what barriers are there to tackling unhealthy lifestyle in practice? So that if generally people know through the media and through health education that these behaviors are unhealthy, what is it that prevents them from making changes? The big reason that people give is they have no time. They're too busy at work or with their family, and there's no time to devote to within the week to taking regular exercise. There's also costs involved, costs of joining a gym, for example. Gym subscriptions are high. The difficulty to get back on the saddle, so to speak, having lost the habit of regular exercise. And the more unmotivated one is, then the mood becomes low due to the inactivity, and they're less likely to be innervated to take up the challenge again. There may be health issues. So if somebody has got osteoarthritis or just a painful joint, they may be reluctant to engage in physical activity for fear that it would worsen their joint situation. They may be socially isolated, maybe single people, maybe people from an ethnic minority who are not part of the larger social community. And the general feeling that most people have is getting over the first few sessions of exercise or smoking cessation or reducing alcohol. The first few sessions are always the most difficult. And these may be used as a barrier to prevent one having to engage with the challenge of making changes in behavior. There may also be societal changes. For example, Tai Chi is very important in some Eastern cultures, whereas it's not practiced much or at all in the West. There may be cultural issues. There may be financial aspects, as mentioned before. The idea that you have to get the best running shoes, the best sports drinks, and so forth, none of which is based on factual evidence, but there's a big industry here, and people have the ideas sold to them that they need to have the best kit in order to engage in exercise. There may be difficulty in getting access to facilities, but there are ways around these. But there may also be differences between, for example, rural and urban communities in terms of ability to engage in physical exercise, as one example. Doctors also say they have limited time to engage in health promotion discussions with patients. They feel that they're not reimbursed for doing this, although it's a big part of their work, and they feel that maybe they should be reimbursed separately for it. They may have a lack of training to engage with patients. They may not be trained in motivational interviewing, for example. Some feel that it becomes confrontational and upsets the patient, and then becomes futile and becomes a battleground between the doctor and the patient. It's interesting also that in the training of medical students in the United States, only 13% of United States medical schools in the year 2002 included physical activity and health promotion and the prevention of disease as part of their curriculum. So this is a multifaceted problem here with all kinds of barriers to its successful engagement. The Oxford Handbook of General Practice, which is our textbook this year, talks about prevention and screening and by defining, first of all, what is primary, secondary, and tertiary prevention, and also looks at barriers to prevention. The idea of blinkering, it'll never happen to me, so you close your eyes to it. A sort of rebellious idea that, well, I know it's bad, but it's cooler. A poor motivation, so that's an easy one to just keep on with what you're doing and not make the change, because it's hard. It's a challenge. Doctor time and doctor money. Health promotion takes time. People find it boring. It takes staff. It takes motivation. And done well, it can have significant results, but it may be difficult to do well. There may not be adequate facilities to do that, or time to do that, or personnel to do that. And also the pressures from outside the individual relationship between the doctor and the patient is on a huge societal basis from big business. Advertising cigarettes, advertising drinks, for example, tasty foods, and so forth. There's been a recent uproar in the UK about one area, York in the northeast of England, not providing surgery for at least 12 months to patients who are smokers and or obese unless they make changes in their behavior. Potential solutions here would be things like local prescribing exercise schemes, which have been run in the UK now since the 1990s. These are provided at leisure centres, which are run by the local council, Metropolitan Council, and provide free or reduced payment services for patients of local GPs. You also have systems where they have encouraging patients to take 5 portions of fruit and vegetable daily, and these were initially run with organized programs, and then the hope is that it would filter out into the general population. The evidence seems to suggest that these are both successful to a degree, but more successful if they are run together. So an exercise scheme plus a dietary program such as a 5-a-day program work better if done in tandem. What about our own habits in terms of physical activity? These are good predictors of your interest and enthusiasm and ability to provide counseling on these issues. Physically inactive doctors from the literature appear to be less likely to provide exercise counseling. Do you think this can also apply to other lifestyle habits such as alcohol consumption, cholesterol, dietary habits, smoking, and so forth? How do you think alcohol problem drinking could present in primary care? Now, you haven't started your family medicine posting yet, but it's still worthwhile reflecting on this. In what way would it present? We can discuss this in class, but have your thoughts ready. There's a variety of ways. If you've already got diabetes and you drink heavily, it can impair the control of your diabetes. It can affect muscle bulk. It can cause poorly controlled blood pressure. It's often associated with non-compliance with medication or reduced compliance with medication, and the long-term effect of that would be things like cardiomegaly from left ventricular hypertrophy, and also heavy alcohol consumption can bring on atrial fibrillation. That in itself, and particularly in the setting of an uncontrolled blood pressure, are major risk factors for the development of stroke. It can also lead to stomach problems and ulcers and gastritis. It can lead to pancreatitis. In men, it can lead to impotence and also infertility in women. There may be cerebral effects like loss of memory, occasionally hallucinations, often musical hallucinations, alcohol withdrawal seizures, and also an earlier onset of dementia and a worsening of dementia control if alcohol continues. Recurrent chest infections, recurrent pneumonias, and these often can be a precipitant for acute rapid AF. You may get clearly hepatic impairment with enlarged and swollen liver, hepatitis, and ultimately cirrhosis. Now, this is irreversible change in liver architecture. You may also get peripheral neuropathy, shaking from a tremor, sometimes due to alcohol withdrawal. And there's also an associated risk of other risky behaviors. So, for example, having unprotected sexual intercourse, giving rise to risks of STIs and HIV. I think what doctors should try to do here is to identify hazardous drinking habits early and to assess a person's willingness to change once this has been broached with them. If possible, help them to reduce or stop, so that you are reducing the harm that is caused currently and also reducing the risk of further harm thereafter, for example, the development of cirrhosis or the development of pancreatitis and so on. When somebody requires specialist assessment, then they should be referred or admitted where necessary. And medication helped withdrawal of alcohol through the use of chlordiazepam epoxide is now well established and safe. You should encourage patients to reduce and stay off, to abstain from alcohol. And you should also maybe use this as a template for using similar programs in other areas of substance abuse. So first of all, you screen or look for the problem, and you try to ascertain where this patient is in the cycle of change. Are they ready to change now, or do they need further support for some time until they are ready to change? When they are ready to change, you may then engage in a so-called brief intervention. The success of brief intervention as a method, particularly by GPs with their regular contact with patients, is actually very good. And this has been shown for weight reduction, for smoking cessation, and also for excess alcohol consumption. So let's look at screening and try to work out what it is. You try to identify through screening people at risk for a disease. You try to determine the probability of the presence of a problem, to substantiate that there is a reason for concern, and identify the need for further evaluation. There are different types of screening tools used. For example, self-reporting during an interview or a questionnaire. So the CAGE questionnaire is quite useful and proven to be useful questionnaire at identifying problem drinking. So this is at the identification stage. Then there may be biological markers. So for example, in patients who are using opioids illicitly, you can use, in conjunction with questionnaires and face-to-face discussions, you can also do toxicology screening to check for multi-drug use. So you may have a patient who has started a methadone maintenance program, but your urine screening shows they've also got amphetamines, other non-methadone opioids, or benzodiazepines in their urine. In patients with alcohol dependence, to identify the level or the impact of problem use, and also to try and facilitate behavioral change. You may do a full blood count or check liver function test to look for these two as indicators of potential ongoing liver damage. This next few screens will show us a variety of questionnaires that are used. Here's an example of the CAGE questionnaire, which is quite useful for identifying problem drinking in primary care. So why screen in primary care rather than secondary care? Now, health systems, health delivery systems vary from country to country, but certainly in the West, general practice is the first point of contact with the healthcare system for most people. And therefore, it's a useful area to apply screening, particularly brief intervention, because it doesn't take much time. And patients see GPs far more frequently than they see consultants in hospitals. And also there's an expectation from patients who have problems with alcohol or obesity or such like, that their GPs would provide lifestyle advice and would inquire about their use of alcohol and other drugs. And contrary to some opinion, most patients are actually happy to divulge and happy to work with you as their GP to promote a healthier lifestyle. In some countries, however, this gatekeeper or primary care role as first point of contact doesn't exist. And some countries don't have any GP system, so it's quite much more difficult in that setting to engage with motivational interviewing and a health promotion program overall. Screening you should look at in some detail because there are pros and cons with screening. It sounds a good idea, but there are issues about whether you simply prolong the level of disease somebody has. And the point of screening is that it's only useful if you can pick up the disease early or earlier when it will have a better prognosis, and when also there is effective treatment available to prevent further complications of that disease. In other words, you make the person healthier and less diseased by using the screening program. If it doesn't lead to that, then may not be worthwhile. So you must have a detectable early stage, and treatment must be more beneficial at that stage than later. And there's a reliable and acceptable and cheap test to detect early disease, and the test is acceptable. So, for example, a blood test or a blood pressure check are acceptable. A lung biopsy as a screening test for lung cancer would not be acceptable to most people. And there's also adequate provision for the extra workload involved. So doctors are already overworked in most countries, and to expect them to provide this service on top of their regular daily clinical service may be somewhat naive, and this should be funded with either extra staffing or extra funding in order to provide a successful screening program. One of the disadvantages of screening is that if the prognosis is not changed by the screening program or by the identification of the disease, then patients simply live longer and with longer periods of morbidity. There may be also over-treatment of questionable abnormalities on screening programs. Also, some screening tests will return false negative results, on the basis of which the patient may be reassured, but this may be a false reassurance. Similarly, and in the reverse order, if somebody has a false positive result, so for example, a lady has a mammogram and it shows a fibroadenoma which is misinterpreted as a carcinoma, then that causes severe anxiety. And even though subsequently the doctor may explain the error, this anxiety level does not necessarily return to normal. This is again repeating just what we've said about screening tests. So let's look at yourself. What's the most recent change you've had to make in your life? How long did it take you from considering it to taking action? Weight loss is a good example here, as that many patients struggle with their weight. Many of us, not just patients, struggle with our weight, and reducing weight is an ongoing battle. There are no easy solutions, as you will see from the range of fad diets that are available online and in the media. Generally speaking, it's quite difficult for patients to make the changes and keep the changes. So the first thing to do when trying to encourage change in behavior is to identify where people are in terms of the cycle of change. The cycle of change is here. First of all, there's a pre-contemplation. This is before you even start thinking about it. You maybe are becoming more aware that your clothes are getting tighter, you're putting weight on. Maybe your wife or partner has said you're putting weight on. You then maybe start thinking about it. You then may make a decision to engage in some action in order to bring about change. But this must be maintained. The initial weight loss from, let's say, the New Year's resolution lasts for a while in most people, but they go back and they put weight on again. And you often get this yo-yo effect where their weight goes back up again. And they may become very disillusioned with this and actually frankly depress some people because they don't get the lasting change. The weight goes back up and maybe even higher to before they began their weight loss program. And then they relapse, and that has all the psychological sequelae, and it's not good. So a lot of thought should go into the contemplation stages. And most people who are faced with a change are not ready to take action at that point. And really all we can do as doctors is help people to move from this area to that area and to go forward and so on. And you may need to get through several stages before actual action occurs in terms of weight loss, for example. What do you think is the result of the wrong intervention at the wrong time? Can you think of any examples of this? Okay, this is a British cartoon from the newspapers of a bygone era. This is Andy Capp, and clearly he's being very pragmatic here. So he'll go for the second best option because there's no way he's going to give up smoking, drinking, and eating fried foods. Andy Capp would have been very popular in the 1950s, 60s, 70s, in that era. So first of all, before you even contemplate change, there's pre-contemplation. You're not considering change yet, and you're actually unwilling or unable to change. So the first thing that a doctor should do in that case is try to raise awareness. That's your challenge, to raise awareness of the problem. The next stage with your support is that the person may begin to contemplate or think about changing, may see the possibility of change, but is uncertain and maybe ambivalent in two minds about whether it can be done or it's worthwhile doing. So your challenge here as the doctor supporting this patient is to try and resolve this ambivalence, to let them see that there are benefits. And the benefits may not be what we would consider as doctors the benefits, for example, reduction in disease, reduction in premature death. It might be about having more money in their pocket at the end of the month. So if, for example, it's to do with smoking or drinking, things one has to pay for, then you might consider getting them to put that money aside, and the motivation to stop and make the change may be that they will actually accrue more money at the end of a period than they would have done, and they'll also will have reduced a potentially unhealthy habit. But the primary motivation for them may be finance, and that's fine. Then you go on to determination. Get them to be determined or committed to changing. Now, they still haven't done anything. They're still thinking about what to do. So you might help to get them to think this through further and identify appropriate change strategies. At the next phase, they're looking at taking steps towards making that change. So the doctor's challenge here is to see the road ahead and see where the pitfalls might be. So, for example, for those who are thinking about smoking cessation, having like ashtrays in your apartment or your house, or for those contemplating reduction in alcohol and they feel they can do it without support, going into bars is not a good idea. And you can work out with them the potential threat, the potential temptation. If they're in a situation where everybody else in their group is drinking alcohol, then they need to maybe find a strategy so that they're not in that setting. People always say that when they are indulging in whatever the behavior, drinking for example, time passes quickly, but when they stop drinking, time goes very slowly, and that slowness of time is in itself an incentive to go back to drinking. They feel edgy, they feel unsettled, they sweat, and this is not just a withdrawal, this is just a feeling that because they haven't planned out what to do, what to fill that void with, for example. And in fact, you may combine more than one strategy here, so that if somebody is a heavy consumer of alcohol and as a result is also obese or overweight, then using, for example, exercise strategies here may help with the motivation for the alcohol reduction, also by giving them things to do that are both healthy but also take their minds off drinking alcohol, and they're not sitting in a bar. They're outside, maybe taking walks. They're maybe in a gym even. But so you've thought this through. You've looked at the potential pitfalls and develop a strategy which the person agrees with that could take them through that pitfall. The next thing is, having made a change, is to maintain it, to keep it going. And that's quite difficult. So you need to help them develop new skills for maintaining recovery. And finally, to preempt recurrence by looking at, during your maintenance, that recurrence may happen and how will we deal with it. and look also at the effect on the person psychologically and how will you deal with that, and develop between you strategies to overcome this. Blaise Pascal was from a long time ago, 17th century, French mathematician and thinker, inventor, writer, philosopher, and he reckoned that people were better persuaded by the reasons they themselves discovered than those that come into the minds of others. So if something is imposed from on high by the doctor, by a consultant, it might have a bit of a scary effect briefly, but it's not sustainable. Whereas if they're involved with it themselves, then they're more likely to take that forward. So these are ways in which this can be brought about, by giving feedback, by listening and understanding their difficulties, by looking at other options and exploring them, and then closing the conversation with a positive way forward. You first of all need to ask for permission to engage in this, and also give sensible, achievable, goal-driven advice. You need to explore the pros and cons of the habit that they're engaged with. Look at their personal strengths, their resources, their previous successes. So what if, for example, a man who's having difficulty with excess alcohol consumption had a period in his life when he was abstinent from alcohol for some years? What was he doing then? What was happening then that he could revisit and maybe make it happen again to help him on this occasion? So it's often useful to draw a timeline with their year of birth and then different parts of their significant events in their lives, and they would fill this in for you, and then you would look at it together and you would see patterns, visual patterns developing, which you could make use of in helping them to take this behavior change forward. So if the patient is agreeable, then you would explore the various options and discuss them. You want to make sure that you're doing this with them and not for them. Encourage them to share their views on what you've agreed, and also repeat what exactly was agreed between you. Again, this is a summary of the stages of change. So in pre-contemplation, you give facts, you explore the meaning of events that brought the person to treatment, you explore the results of previous efforts, and look at the pros and cons of targeted behaviors. Next, you move on to contemplating, so really thinking about it. What about their sense of self-efficacy? What about their expectations, what the change will entail? What about self-motivational statements? And again, continue exploring pros and cons. At the next stage, you offer a menu of options for change. You identify again the pros and cons of each. And you look at what barriers there are, that there's no time to do this, I'm too busy, and then see how you can work around that. Help them to enlist support. So weight reduction is easier done if a husband and wife do it together, or boyfriend, girlfriend do it together, similarly with smoking cessation and so forth. And encourage them to make a commitment by publicly announcing their plans. So for example, this will be discussed, a man will discuss it with his wife so that they know they have an agreed date when he's going to start doing this. You then look at the action and make it a realistic action. And if you feel that the patient is being unrealistic, then you should tell them this and give them small, achievable steps. Identify situations where they could be at high risk of relapse and help them to develop a coping strategy to preempt this. Try to find new ways of reinforcing the positive change in behavior. And again, ensure that they use social and family support. Friends and family are very helpful in helping you to engage with behavior change. And if they know about it and they're actively involved in it through sharing it with them, then they will help you. Maintenance is a difficult part of the whole program. So looking at other ways of alternative behaviors, for example, if the problem has been drug addiction, looking at deriving pleasure from other sources other than drugs. Maintain supportive contact, be available. Develop an escape plan. Their work to set new short and long-term goals. In some groups, such as Alcoholics Anonymous, for example, it works on a buddy system, and you have a buddy or mentor who will support you and is available. You'll have their WhatsApp. You can contact them when things aren't working out. And then recurrence and dealing with recurrence. See it not as a sense of failure, but as a learning opportunity. It's not a threat, but an opportunity. Explore possible behavior, psychological and other antecedents. What do you think has led up to this? And what could you do differently to stop this happening again? Look at new or better coping strategies. And continually support and explain the stages of change in order to encourage them to stay in the process. So all of this is underpinning what you will do in week 2, which is together producing a video highlighting the health promotional challenges in the scenario shown here and how to use motivational interviewing to aid changes in behavior and lifestyle. So in your scenario, you have a patient called Raju Kamalaswaran who needs a hip replacement for an increasingly painful osteoarthritic right hip. He's an Uber taxi driver, but he can't work now. He can't sit for too long, and when he does, his pain gets much, much worse, and he's very stiff and there's difficulty getting around. His weight has increased over the last 12 months, partly worsened by the fact that he's a taxi driver, but now, alarmingly, his BMI has gone up to 32.5. The clinic at Hospital Kuala Lumpur have postponed his surgery and advised that he lose weight. They're concerned about post-operative complications particularly, and also that continuing his level of obesity will put greater pressure on his new joint. They said they will review his fitness for surgery in another 6 months. So in desperation, he's come to you as his GP. He's your next patient today. So this is the scenario for which you develop your video. These are some references looking at various models of changing behavior and motivation interviewing techniques, looking at screening services in Ireland, and looking at major causes of death and what we should be doing to try and use health promotion and motivational interviewing to prevent these diseases occurring and prevent them causing premature death. And also there's some introduction to the Malaysia report to the WHO. Thank you.